right, thank you. All right, we'll get going again for the after morning tea session. So I'm Kathy Sherrington. You heard about me earlier, so from the George Institute and the University of Sydney. So we'll just wait till everyone quietens down. Should get someone to whistle, should I? All right. Okay, it's fantastic that everyone's having their dynamic interactions, but let's keep it quiet now and start the next session. So, it's my absolute pleasure to introduce Dr. Lara Harvey. Lara is an NHMRC Early Career Research Fellow in the Falls and Balance Injury Research Centre at Neura. And that's actually a huge achievement these days to get one of these NHMRC Early Career Research Fellowships. They're very hard to get these days. So Lara is an injury epidemiologist, and her research areas of interest include population-based trends in injury and the evaluation of population-based policies and regulations and legislation. Her current focus is exploring the influence of dementia on hospitalisations and health outcomes for people who've sustained a fall-related injury. And today Lara is talking to us about fall-related injury in people with dementia. So welcome, Lara.
Not entirely sure why there's a security alert on my slides, but they're very precious. Thank you so much for the organisers for inviting me to speak today. It's a great honour to be invited to do a plenary session. Before I start, I would also like to acknowledge especially the NHMRC, who have very generously funded 4 years of my research in looking at data. And I'd also like to acknowledge the DCRC. So a lot of what I do involves analysis of linked data sets, and I don't know if you're aware, hospitalisation data, it's free, it doesn't cost anything, but linking it to anything else costs an absolute arm and a leg. And by the time you link state data in with Commonwealth data, you have to mortgage your house. So I'd like to thank the DCRC for providing a series of project-related grants that has allowed us to pay for the linkage of the data. So what I'll be covering today is just a basic general overview, looking at the global impact of dementia, where we are in Australia in terms of dementia, cover briefly a bit about background around what we know about dementia and falls, and a lot of the information to date has come from relatively small or smaller clinically based trials as opposed to data at the population level. Mostly what I'll talk about today is hospitalisation trends from New South Wales so that you'll get a feel for what's happening within the hospital system for people with dementia in our state. Now, when I was first asked to do a half-hour plenary session on data, my first thought was, are you sure? So it does come with a bit of a health warning. There are lots of numbers and graphs in this presentation, but I also would like to say, prior to being an epidemiologist, I was a physio. So hopefully what I present today will have some clinical relevance to you, that each of you can bring something back from it that will be relevant to your workplace. I also want to highlight, I think moving into data linkage studies, it's such an exciting area to be into. And so partly also looking at what we've done and what we can show, but what our next steps are, because a lot of epidemiological research, we're hypothesising, we're raising ideas, raising issues that then needs to be explored further. So it was estimated only last year that there's currently 47 million people living with dementia worldwide, and that there's one person diagnosed with dementia every 3 seconds. Personally, I find that quite frightening. So that by 2050, there'll be 131 million people living with dementia globally. Dementia is expensive. Dementia care is expensive. It's been estimated that in the US, there's $800 billion spent annually on dementia care, and that by 2030, this will have blown out to over $2 trillion. It's also, and this data comes from the Alzheimer's International report that they put out in 2015, But they estimate that the greatest increase in dementia prevalence is going to occur in low and middle income countries. And unfortunately, these are the countries that are least capable or least able to pay for the care that's required. However, despite these somewhat alarming headline figures that we see, there's some global trends. And so that there's some evidence from some, and it's mainly high-income countries, that the rates of dementia are plateauing and may even be declining. I say a lot of this evidence comes from high-income countries because we don't really know. Dementia prevalence isn't currently counted terribly well. A lot of what we know is extrapolated from longitudinal population studies where they take a cross-section of the population and maybe take a similar cross-section of the population 10 years later. So they're estimates. And until we have establishment of, comprehensive dementia registries, we really won't know. The reason for why there's a decrease in dementia prevalence also is not particularly well understood or really has yet not been fully explored, but it's believed to be linked to improvements, in education and how, exposure to more stimulating environments earlier in life. And it's this building of this concept of increased cognitive reserve, whereby later in life, with a bigger brain size, with greater morphological and metabolic complexity, you can afford to lose more of your brain before you start impacting in physical and other problems. And so there's been studies that have estimated that having a high cognitive reserve halves your risk of dementia later in life. And they've also done studies that estimate that the population attributable risk of education is about 20%, so it contributes about a fifth of the reasons for why you may develop dementia. The other reason that we might be finally seeing some decreases in dementia is a more aggressive management of cardiovascular risk factors, because they now know that brain health is very much linked to the health of cardiac health also. So with this expansion of programs into looking at reducing hypertension, diabetes, high cholesterol rates, obesity, increasing physical activity, which we're all very passionate about, we are also improving brain health. And so it's, again, these prevalence studies estimate that these brain health matters contribute about 25% of the population attributable risk for dementia, and that by optimising your physical activity and your stroke risk factors, you could prevent about 10 to 15% of dementia. But where are we in Australia? So this data comes from the report released around 2012 from the AIHW, and again, everything I do, I stress, these are estimates. So around 340,000 people currently are living in dementia, and again, it's expected to surpass to 900,000 people by 2050. So really, what we know of all Australians aged 65 and over, 9% have dementia. So if you're in a row of about 10 people, that's about one of you in that row is going to have dementia. By the time you reach age 85, it's 30%. So it's going to be 3 of you in that row that are going to have dementia. But I also it's important to note, even if the population prevalence does decrease or it does plateau, purely by the increasing numbers of people living older, the numbers of people with dementia is going to continue to decrease over the next decades. There was a very interesting and very good piece of work relatively recently released that's publicly available, and it was by the AIHW, that then looked at the impact of dementia on hospitalisations. And what the study found, which we've sort of known from clinical studies, is that people with dementia have significantly higher hospitalisation rates than people with dementia of a similar age. But what hadn't been really highlighted was that injury has been shown to be the most common reason for hospitalisation for people with dementia. But despite this, there really was relatively little known at the population level about these hospitalisations for people with fall-related injury. Oops. So what do we know about dementia and falls? We know older people fall, that's why we're all here. We know that around 1/3 of adults aged 65 years and older will fall each year, and 1 in 10 of these falls are going to require hospitalisation. We know older people with dementia fall more often, so around 60% of adults with dementia are going to fall each year. So it follows that dementia is an independent risk factor for falls, but why? What is it about dementia over and above the fact that they're older and frailer that's going to make it a risk factor for falls. And that's very much the focus of a study of a colleague of mine, who's also my Fitbit buddy, is currently beating me. But her PhD has focused very much on trying to tease out that very question about what is it about dementia that increases the risk of falls. I keep teaching. And what she's found, and if you're interested in this area, I really do advise you go Google some of her papers. They make very good reading. But what she's found is that balance and mood are independently associated with falls with people with dementia. And what's also really hopeful about that is that these are potentially modifiable things that can be acted on. And it's certainly very much the focus of the work she's now doing around preventing falls in people with dementia. I know she's presented previously in this forum, and she's also presenting some of her work this afternoon in the afternoon forum, which would be well worth listening to if dementia is of interest to you. So again, what do we all know? And I'm sure everybody in this room is familiar with these kind of figures. This particular graph comes from the AIHW, and it's looking at falls rates across hospitalisations for falls across Australia. And what it does show is that it's rising despite all our best efforts, all our research, all we currently know. The rates are still age-standardised rates, so it's not just because people are getting older, are rising in Australia. And it's rising at about 2.3% per year. What I wanted to highlight, though, is that it's not a consistent rise across all age groups. So people aged 85 years and older are increasing at a significantly higher rate than for the people in the younger age group. So that's national data. But if you have a look at this is actually data from New South Wales specific. It is publicly available in a report we published a few years ago, and it's on the Neuro website. But what I wanted to draw your attention to is in New South Wales, that trend of increased hospitalisations is more dramatic in our oldest old. That's the light blue line across the top. We're increasing at a higher rate than the national average. So what do we know about the impact of dementia and fall-related injury? So I've already highlighted trends for hospitalisations are continuing to increase, but within that, there's big differences between injury type. So we know that hip fracture rates in Australia and in some countries are increasing, and certainly in our New South Wales data, hospitalisation rates for hip fractures are decreasing about 1.3% per year. This is not the case for all countries. Some countries, Spain, the rates are increasing. The UK, whom we usually track quite well against, have also shown increased rates for hip fractures. Traumatic brain injury, however, is increasing dramatically, and this is across the board in all countries, and it's increasing at a rate of around 8.6% per year in New South Wales in the older population. We know people with dementia are 3 times more likely to have a hip fracture, and this comes from clinical trials. We also know that people with dementia are 2 times more likely to have a head injury. So I guess there's really 2 questions arising. What are the differences in hospitalised characteristics and health outcomes for individuals with and without dementia that are hospitalised for fall-related injury? And what impact is this increased number of people living with dementia having on these very disparate injury trends? So that's really basically what a lot of my first year of my work and my fellowship's been trying to explore. So the rest of this presentation really just focuses on data, trends in New South Wales. And what it comes from is we've linked hospitalisation records for over 230,000 individuals aged 65 years and over, admitted for a fall-related injury, and we've linked them to death records because we want to know what happens to them over time, not just what happens in hospital. So this is a really huge sample sizes. So when they talk about clinical trials, I have no problems finding statistical significance because at this number of people, the slightest variation is going to be statistically significant. And I want you to bear that in mind when I'm showing you some of the results. So we calculate age standardised rates against the population. We identified dementia and various comorbidities. And this is important because these results are only as good as the coding in the hospitals allow. These are administrative data sets, they're not set up for research purposes. But we do know that for a patient in hospital that has dementia, that hospital will gain extra money. So there's incentive to code for dementia. So if there is a known case of dementia, it probably will get coded. Certainly the severe cases will. There's evidence from lots of stats papers that by using a 1-year look-back period, so we actually look back a year at all hospitalisation records for an individual, and if dementia has been mentioned in those records, we'll include it for a year after that. So we've used a 1-year look-back. We've really tried to tease out the role of dementia versus other known confounders, so sex, are they older, are they frailer, is there variation in admission practice, so we've tried to tease that out. We've analysed trends over time, and then also we started really playing with costs, and I think Kathy alluded to this. Money matters. If we can then go to the policy people and say, look, this is how much it's costing, we're going to have a much better basis for what we're trying to argue. So basically, out of all the people admitted to hospital with an injury over 65 years, 91% of those injuries for people with dementia were falls. So basically, falls is really the main mechanism that people with dementia are injuring themselves. And I think a lot of that's got to do with exposure. A lot of coming from residential aged care facilities, they're not out and about as much. So transport accidents, burns, these sort of things aren't as common. So just going back to the demographic characteristics, these are the people in our hospital. They are predominantly female, which we thought they would be. They are predominantly older than people without dementia, and they are predominantly frailer, which reinforces the need to actually adjust for that when we're looking at characteristics. So overall, 21% of all hospitalisations for people aged 65 years and over were for people with dementia. Now, I've already said this only represents 9% of the population, so they're very much an overrepresentation. Where they happened was predominantly big difference between community dwelling people and people with dementia predominantly came from residential aged care facilities. So in all my slides, the red section represent people with dementia, the blue section represents people without dementia. Having said that, we do have to take this particular graph with a big pinch of salt. We don't really know where people came from. That's one of the main limitations with New South Wales hospitalisation data, is that they don't code well for residential aged care. Some hospitals do, some don't. So these are just estimates. I suspect the proportion that comes from residential aged care is actually a lot higher. When we look at the causes, and this is where I was saying I've put little stars to indicate significant differences between groups at the 0.0001 level. Pretty well everything's significant, but it doesn't mean it's clinically significant. But predominantly for both people with and without dementia, the main cause of their fall-related injury, hospitalisation, is as a result of a slip, trip or fall on the same level. It's different for people with dementia in that you've got a higher proportion that fall involving furniture. So again, falls from beds, falls from chairs, much higher in people with dementia. Whereas steps, stairs, falls from different levels aren't as common. And again, that probably reflects exposure and risk, that they're just not doing such high-risk activities. It starts to get interesting. So we look at what type of fracture injury is a difference between people with and without dementia. And certainly, and this is very much reinforcing what was found in the clinical trials, is that people with dementia, a higher proportion are coming in with a hip fracture, but they're not coming in nearly as commonly with other fracture types. And again, there's a different pattern between people with dementia and people without dementia. They're coming in with their non-fracture injuries. So people with dementia are coming in, a higher proportion are coming in with head injuries. And interestingly, on this graph, and I'm sorry, my dots, my asterisks don't seem to have shown up, the one thing that wasn't significantly different was TBI. So in terms of proportion, that's not different between people with and without dementia. But this is where I think it gets really interesting. Apart from the fact I'm very proud of this slide because it took hours to make. But what it is, and I think it's worth exploring, is it's a forest plot, obviously. So on one side, you can see that people with dementia, so this is in relation to people without dementia. People with dementia are at lower risk of being admitted for an injury, and on the other side it shows clearly that the people are at a higher risk. And here we have adjusted for all the known factors that we can. So we've adjusted for age, we've adjusted for sex, we've adjusted for frailty as much as we can through comorbidities, and we've adjusted for changes in admission pattern. And what this clearly shows is that people with dementia are 58% at a higher risk of being admitted for a hip fracture than people without dementia, that they are 14% higher risk of being admitted for a non-fracture head injury, and that they are 9% higher risk of being admitted for a traumatic brain injury. So these are significant injuries. When we look at what happens to them once they get into hospital, and so you look at just overall length of stay, and a lot of the literature says that people with dementia have longer lengths of stay. If you look at it for injury, that's not so much what we find. There is a difference, it is significant, of course, but people with dementia on average have a length of stay of 17 days, where it's 15 or almost 16 days for people without. So overall, that pattern's not so strong with injury. But what that also masks is the individual variation. So again, one of my very favourite little box plots here is when you do adjust for the fact that they're older and they're more female and whatever, what you find is for all injuries, people with dementia do have a significantly longer length of stay, except for hip fracture. And that's what's pulling that overall trend down. So for hip fracture, they're in for significantly shorter periods of time. And there's a bit of a dilemma as to why that might be. And partly it could be linked to rehabilitation being offered. So we know that at least 50% of people with dementia have come from residential aged care. Therefore, they may go back very quickly without being offered the ability to have rehab. Because we don't actually know where they've come from, we can't really measure that in this particular study. But there are clinical studies that do show that for people with dementia that do receive rehab for their hip fractures, actually physically do quite well. So this is something I think that we need to tease out further. The news isn't good mortality-wise. So previously we could only measure in hospital mortality. Now we can look at what happens over 30 days, which is a sort of an internationally accepted standard. And as you'd expect, people with dementia do have a higher mortality rate at about, overall, 8.8% compared to 3.9% for people without dementia. But again, is it older? Are they frailer? And so in my box plot, adjusting for these, they still have a significantly higher mortality rate. I would also like to make the comment that in this one you'll notice my confidence intervals are so much wider. That's not just a typo in my graphs, that's just because mortality rate's much rarer, so your sample size has gone down, so the surety around our estimates is not as great. But still, we're finding very significant differences. In my point about rehab, specifically with hip fractures, again, we can't tease out where they came from or the reasons for this, but when we do look at proportion that receive in hospital rehab, it's quite low anyway. For hip fractures, people with dementia, over half of them received acute care in hospital rehab at that time of acute admission, and that drops to about a quarter of people with dementia. The differences aren't as marked for other injury types. So trends. So what's happened over time? And this is probably my most unexpected finding. And believe me, I have analysed this so many different ways at so many different times, and it still comes to the same answer. That this decrease in trends in hip fractures that we've seen is only occurring in people in dementia. So people with dementia decreased by about 4.6% per year, but the rates have remained constant for people without dementia. So it's almost looking like people with dementia are driving the decrease in hip fracture rates that we're witnessing in New South Wales. This needs further investigation. We can't really explain it. But one thing I do want you to note, so the dotted red line is numbers, and the blue lines are rates. And I noticed, I made a big issue earlier about the fact that we don't know what the prevalence is in. So I've actually modelled both lots. So I've modelled assuming you keep the prevalence rate the same, or that the prevalence rate is increasing. So one blue line's keeping the same, one blue line's increasing, but it doesn't change the trend at all. the trend is still consistent no matter which rate you model. And it's different. So what's happening in the hip fractures is slightly different from what's happening with other fracture types. So hospitalisation rates for other fractures have decreased in dementia as well, but they've actually increased in people without dementia. So we're getting opposite trends here, which is interesting. But then when you look at trends in non-fracture injuries, it's actually increasing in both. So the increase in rate is slower for people with dementia, but it is increasing. And it's increasing about 2%, 2.5% per year, which is in line with what we know about injury generally. But for people without dementia, it's increasing about 6.5% per year. So it seems like, we're doing quite well with fractures, but we're not doing so well with soft tissue injury. And traumatic brain injury, I think, is a really, gosh, I've been speaking more than I thought, a really interesting one in that it's increasing dramatically for both people with dementia and without dementia. And we don't know why. This is a paper I published a couple of years back now, really starting to tease out what's going on with TBI. And one thing it does show very, very clearly is that it's the intracranial hemorrhages that is driving this increase. So that top line that's skyrocketing is your subdural hemorrhages, your bleeds. We do know that with increased use of anticoagulants in the older population that this is an increased risk, and it's something that we need to really tease out a lot more. I mentioned that I was going to look at costs, and we've started really playing around a lot. It's so much fun playing with data with these and what we can do with modelling this. So this is only in the last 2 years worth of period because, trying to project costs over 10 years, there's so many things that change. But over just a 2-year period, it has cost $1,226, I'm getting a bit blind, $1 million over a 2-year period, of which $263 million was for dementia. So that's 21% of total costs was for people with dementia. We know that the average cost for a care for a person with dementia is higher than a person who doesn't, except, and the noticeable exception for that is to do with hip fracture care, because they're in for shorter and costs obviously are associated with length of stay. And that's something we're going to play around with modelling a lot more into the future. So in summary, people with dementia contribute a disproportionately large proportion of hospitalisations. They're more likely to be admitted with hip fracture and head injuries, but less likely to be admitted with other injuries, notably upper arm. Now that may just be a reflection that if you're a resident in a nursing home, you go get your GP or you might go to ED and get it fixed and then you go home because you're managed. Whereas if you're a community dwelling, you may not be able to manage at home with an upper limb fracture and so you're being admitted more. Or it may actually be reflective of the fact that people with dementia are not able to stop the fall. So they're not responding early enough to put their hand out to stop the fall, so they're not fracturing their wrists but they're fracturing their hips. And clinical studies would suggest that that is the case, that's what's happening. We know they have a longer length of stay for all injury types with the very notable exception of hip fractures. They have higher 30-day mortality, and that the trends over the last 10 years have differed between those with and without dementia, but we don't really know why. And this is where I think it starts to get really interesting. And this is what I was saying earlier about this directions for future research. Because currently we can't disaggregate the role of being in residential aged care, we can assume that it's because residential aged care has improved, because falls are less, hip fractures are less. We can't prove that, we can't show that. So the next step of what I'd like to be doing, and which we're currently working on, is we've been able to link the hospitalisation data with the Commonwealth data sets for residential aged care. So we will know exactly where they were at that time of that fall. And we will know if they weren't, if they're community dwelling, we'll know accurately, do they then go on to become residential aged care. We've also linked it to aged care assessment project data, so we'll also know functional outcomes, which I think is very exciting. So this is work we're currently working on, and hopefully at some stage in the not too dear future I'll be able to share the results of it. The next step, which I think is even more exciting, it's even bigger linkage, is exploring the relationship between primary care, so GP providers, preventive care, osteoporotic medication, psychotropic active drugs, the anticoagulation. So we'll know about people with factors from the 45 and up study. We'll know how much exercise they say they do. We'll know what medications they're on because I can link that to the MBS PBS data set. Then we look at the hospitalisation. then we look at the outcome. And these are the kind of studies that we're only just beginning to be able to do. And these are the ones that cost the arm and the leg. So my time is up. I'm getting the big red tea. I would just like to thank my co-authors and all the work that I do. As always, there's a team involved. So Associate Professor Rebecca Mitchell, Professors Henry Brodati, Brian Draper, and my boss and mentor Jacqueline Close at Neuro. And I'd also like to thank the Ministry of Health and the data custodians that provide the data extracts that we get to play with. And if anyone else is interested or would like some more information, please feel free to contact me. I love talking data. In fact, I'm beginning to think an hour's worth of talk would be great. So yeah, send me an email. I'd love to talk to you. Thanks.
Thank you so much, Lara. That's really very well communicating your passion for data and the importance of your questions that you're investigating. We've probably got time for one or two questions. Does anyone have a burning question? If not, we hope to have a bit more time at the end of the session. Oh, there's one.
Could you just tell me, where do hip fractures, what are they called? A hip fracture is called lower limb injuries or trunk injuries, or?
I've separated them out as hip fractures.
So, no, I'm sorry, I didn't mean hip fractures, I meant pelvic fractures.
Oh, right, okay. Lower limb injuries. So in most, it depends on which report you're reading. So under the this is all done in ICD-10 coded data. So hip fractures are pulled out separately, and then usually everything else is lower limb fractures. So your pelvic fractures tend to get hidden in there, but they can be pulled out separately.
Excellent. One more burning question. I think someone there.
Hello, I'm wondering if you've looked at any geographic variations in New South Wales?
One of the early reports that has been published that's publicly available, we looked at variations by local health districts. But in terms of hospital type and other geographical variations, it's something that we're doing but haven't actually published any work on it yet. But if there's anything particularly you're interested in, find me and I'm very happy to do it.
Excellent. So thank you very much, Lara. That was fantastic. So a small token in appreciation. Oh. Better put that on Instagram straight away. So now it's my absolute pleasure to introduce Professor Susan Kurrle, who's a geriatrician at Hornsby Kurrle Hospital in northern Sydney, as well as at Bateman's Bay Hospital in southern New South Wales. She also holds the Kurrle Chair in Healthcare of Older People in the Faculty of Medicine at the University of Sydney. Sue has a long interest and involvement in practice and research in prevention of falls and fall-related injuries, as well as in the use of exercise to improve fitness and prevent frailty, as well as in dementia. And she leads the NHMRC Cognitive Decline Partnership Centre, which has a number of projects addressing functional decline and falls in dementia. And today she's going to tell us about that work. So welcome, Sue.
I'm not sure I can be quite as passionate as Lara about data, but I do absolutely understand how important it is. And she's already said the thing I was going to start with, which is just talking about how common dementia is. And often when I go to talks like this, I actually get everyone to stand up and then sit down when I get to the age that they want to die at. Now, I won't do that with you today because I can tell you over many conferences that I've spoken at, most people want to live to 85 or 90. Not many want to get to 100. At 85, as Lara said, 1 in 3 of us will have dementia. That means if you don't have it, you're probably going to be living with someone that does have it. At 90, it's 1 in 2. But what's really interesting is that after 90, it doesn't go up further, it doesn't appear to. So get to 95 and you might be okay. However, falls has been my real interest. I actually did my PhD in hip protectors, why older ladies do or don't wear hip protectors. And I can tell you vanity is a very large part of it. But it was falls is, and I guess dementia is huge. And what I've been asked to talk about today is the partnership centre that I lead, I guess for the NHMRC, and some of the projects we're doing. And just a little background to the Partnership Centre. There's lots of partnership centres. This is one of the partnership centres for better health. And in fact, there are only 2 in Australia. Ours was the first. We have $25 million over 5 years to address the area of cognitive and related functional decline in older people. And the second one, incidentally, is prevention, the Australian Prevention Partnership Centre. They came into being because the NHMRC were getting lots and lots of complaints, particularly from clinicians, but from providers who said, all this money goes to research and we never see any practical results on the ground. Please address it. So they did. And the idea of partnership centres for better health came into being. So what is the Partnership Centre? It's a partnership between NHMRC, who provide most of the money, Alzheimer's Australia as the major consumer organisation, and then 3 aged care providers around Australia. In WA, it's Brightwater Care. In New South Wales, it's Hammond Care. They're also in Victoria. And in South Australia, Helping Hand. So they are the partners. They actually contributed money as well as NHMRC. And they drive the agenda for research. So it's not researchers coming out and saying, I've got this really good idea, let's look at such and such. It's the partners saying, we want to know if this works, or why does this cost more than this? And I'll describe some of the projects that we're doing. What has been really different about the Partnership Centre is our work with consumers. From even before we started, we had the Consumer Dementia Research Network from Alzheimer's Australia involved. That's people with dementia, early dementia, usually, and carers or graduate carers. And they have been absolutely key to a lot of the projects. And we haven't done a lot because they've simply said, that's irrelevant, that's pointless, it doesn't mean anything. So we actually started about 2.5 years ago. But just who are we? We're a real mix of clinicians. So I'm a clinician, I'm a geriatrician, that's my day job. And researchers, consumers, aged care providers. So we have a large number of people who work in aged care organisations involved. And we're right across the discipline. I think there's 15 professions involved. You've got your standard ones, you'd expect medicine and nursing, but we have lawyers, sociologists, and it's made for the most amazing interactions, it really has. And the consumers I mentioned before, so we're 5 states, 10 universities, and lots of other assorted institutions, including ACI in New South Wales and Southern New South Wales LHD. These are very dry slides, I'm sorry, but I have to say this is why we're here. Our main objective is actually implementation, not research, implementation. And then synthesis and dissemination, I'll explain and give you examples, then research and capacity building. So we're actually set up to implement stuff, not just research it. So knowing to doing is really what we're here for. And I've said already, end users are really involved. Our aim is really simple, to improve the lives of people with dementia and to provide and develop and provide research findings, so good information to people who are working with people with dementia. So we're particularly the care area, not the cure area. I do wear another hat, and we run clinical trials at Hornsby, where I work, where we're actually doing drug trials in people with dementia. And we actually, the myostatin study that Stephen mentioned, we actually got involved with that. We still have a 12-step staircase that leads nowhere because one of the tests was a 12-step staircase. It's a really good conversation piece. We are looking a little bit at the cure, but we are into care. We are into improving care of people with dementia. We're different to other centres because most of the activities are actually initiated by providers. They ask the questions and then the researchers work out how to deal with it. We have, as part of our centre, 5, we call them enabling subunits, but we've got a health economist who will help anybody in the centre with any health economic stuff. Her name's Tracy Comans. She was a physio before she did her health economics. It seems like physios like numbers. Research methodology, so if you want to know how to do the research, that you help with that. Change management, probably the biggest thing. How do you change behaviour? Policy development, we don't want to just implement, we want to be able to change policy at a state and national level. And the reason I think we are reasonably successful is a lot of us are clinicians, and we can actually take the results of what we're doing and actually do it in our work. And CHOPS, which I think you've heard about before, I'll just mention briefly, which is care of the confused hospitalised older person in acute hospitals, and our clinical practice guidelines, which I will bang on a bit about later, are both examples of where we take what we know but actually implement it in the workplace. Some examples, and I'm not going to talk about all of them, there's actually 33 activities, but I'm going to talk about some of them. CHOPS, I think, has been presented here before, the Confused Hospitalised Older Persons program. With New South Wales Agency for Clinical Innovation, our partnership centre has funded the rolling out of that into 12 hospitals across New South Wales, and we're also looking at and the evaluation. And we have one PhD student looking at the care of looking at carers' experiences. And I've just put up, I think on the right. The 7 principles is absolutely so important, and we preach those, I must admit, all around the country. What's interesting with CHOPS, because it's all up there on the website, is we have hospitals in Western Australia and hospitals in Queensland actually taking it on and doing it. No cost, we're not implementing it, they're doing it themselves, but because the resources are so good, they can do it very well. So CHOPS is something we're into sort of the evaluation phase, but as a clinician in a hospital that has CHOPS, in fact 2 hospitals, because we piloted at Bateman's Bay, it's fantastic. I don't know how many of you have worked in hospitals, but the difference it has made in the care, I think, is really important. And we've actually just opened a proper dementia unit within our acute hospital wards. The funniest thing is, they said paint the walls bright colours, so we have bright blue and bright yellow wards, something you don't see anywhere else. But it seems to be good. So CHOPS is ongoing. Vitamin D, very topical. Thank you, Stephen, for bringing it up. The guidelines around vitamin D for older people say really all older people in residential care should have vitamin D supplements. If you look at what happens around the world, in a lot of countries they put it in the bread or the milk. In New Zealand it was basically legislated that every resident in aged care facilities would be given vitamin D unless there was a good reason. So we thought this is a really good, really easy implementation study, we'll do it. Well, no. The barriers have been fascinating. We started the study by looking at how many people are taking vitamin D. Despite the guidelines saying it should be close to 100%, it was 47%. So we know they're not getting adequate vitamin D, but the barriers that have come up to doing it, people who work in the facilities say, no, we'll just put them out in the sun. And we say, no, well, actually, as Stephen pointed out, it doesn't work. They won't go out or they're not put out. Oh, we'll exercise them. Well, it doesn't happen. So we're working on that, but there are some really good educational materials already available on the website, and I'll put the website up at the end, but if you just Google Cognitive Decline Partnership Centre, it'll come up. Lots of stuff available for people to use, including the video. There's quite a good video. So more examples of implementation. Telehealth-enabled prescribing. in dementia, for people with dementia in aged care facilities. And this is people in facilities that are 300 kilometres plus away from large urban sites. So we're doing it in rural, regional and remote areas of Australia where a geriatrician sitting, in this case in Brisbane, and he's down there on the right-hand bottom corner, Len Gray, and his colleagues will provide advice out into facilities. He's done quite a bit of work in this area, and we're looking at it particularly around good prescribing. Stephen also mentioned occupational therapy interventions. Caring for older people with dementia in their environment is a well-documented intervention done by OTs with people in the community and their carers. We're just about to implement that in Australia, which is fantastic. And it's mainly occupational therapy and also nursing intervention, but there's quite a lot of exercise involved in it. But it's a very sensible approach, so we're getting that out there. Implementing interprofessional education. This is having medical students, nursing students, social work students, physio students, all working together and in a residential aged care facility. This has been done really well in Western Australia. 3 of the universities place their students in residential care, and that photo on the bottom left is actually one of Curtin University's photos from Brightwater Care, one of our partners. It has been very successful and the health economics is amazing. What's really good is that people come back after they've graduated into aged care because they realise it's actually a lot of fun. And that not every physio wants to do sports medicine. So I speak as the mother of a sports physio who still sees lots of older people. But now, synthesis and dissemination, so pulling together the research and then getting it out there. Advanced care planning in Australia. Lots of people have done this, but we've pulled together all the information. It's available as a report on the website. And we don't just pull it together, we now disseminate it. Next Monday morning at UTS, there's actually a workshop looking at how will we start getting the message out there? How do you promote advanced care planning? And that's particularly, it's not just doing an advanced care directive, it's the whole, how do you get enduring power of attorney and enduring guardianship taken up? The role of key workers in dementia is a work in progress. There's a lot of politics around that because key workers in younger onset dementia have all been rolled in to the NDIS, and older people with dementia don't have it. So we're looking at that at the moment. The guidelines, which I'll talk about in a minute if I've got time, are really important, I think. So we have now clinical practice guidelines for the first time ever in Australia. Collaborative new research, and the first one is really interesting, understanding long-term care configurations. Really, what is the cost of quality dementia care versus bad dementia care? And there's just 2 photos that I show you. I class the picture on the left as bad dementia care, the picture on the right as good dementia care. And that is being looked at, and this is one that is not popular with the Commonwealth Government. In fact, they tried to stop us doing it. But it will be very interesting to get the results of this. So we're actually interviewed lots of people in lots of sites, including the site where that lady, who happens to be my mother, is playing the piano with her great-granddaughter. And it's the care, I'm just blown away by the difference compared to the other. Another one, public well, I can see you've all gone to Zora. I'll mention Zora first. So Zora is the robot. So understanding the effect of a socialisation robot on older people with cognitive impairment. Do they work? We know there's been a bit of work done with Paro, the seal. This is Zora, who I met on Monday in Perth. Actually, she says, "My name is Zora, but call me Alice." Apart from occasional, she just sits down and doesn't do anything for 20 minutes because she's run out of battery power. It's quite interesting to see, but is it actually good? Because someone has to operate it, and would it be better if that person was just interacting with older people rather than operating the robot? So it's an interesting area, and we're looking at it quite carefully. And from that going right to the top, so the first dot point, understanding public attitudes to dementia and the whole issue of stigma. How come in Japan and in some of the dementia-friendly communities, they do it really well? They've got bus drivers, taxi drivers, bank people. Everybody's used to, they understand about dementia, and police. And so looking at how do we change those attitudes, and we're working obviously very closely with Alzheimer's Australia for those. Second dot point will be talked about a bit this afternoon when Morag Taylor, who was the girl peering through the hole in the fence in Lara's picture, she will be presenting this afternoon. They're actually in her team, she and her team are involved with our with the Partnership Centre, again in teasing out this incredibly difficult area of falls in older people with dementia. And I can tell you it's not just older people who fall. A couple of my patients with dementia in their 40s and 50s fall regularly as well. They just don't injure themselves, they bounce more. Capacity building, PhD and master scholarships, yep, we do that. What we've really done that I think is different is we've got staff in residential care who have never done research in their lives to start thinking about what they can do and getting involved in research, and that's been really, really lovely. The only problem is once the project finishes, what do you do then? And that's what we're dealing with now, because you start to build capacity and interest. The other thing we've done is have lots of workshops. And we've had one recently on telehealth and technology, which was quite interesting, and the whole concept of the driverless car. I can tell you my mother, who has moderate dementia, if she got in a car with no driver, she would be so anxious. But I think they definitely have their place. And we have an annual meeting where everybody in the centre comes together, and we have 80 to 100 people coming to that, and it's really, really great because it's not just researchers, it's clinicians, and everybody learns from everybody else. Okay, and finally I just want to talk about the clinical practice guidelines, and again fairly dry, but I will die happy now because this is the one thing I really, really wanted our Partnership Centre to do, because there aren't any guidelines. And 8 years ago, my general manager, where I was working at Hornsby, said to me, he said, I had a look at the NHMRC website. Why aren't there any guidelines on dementia? Don't they think it's important? And I thought, that's a general manager's view. There's guidelines on musculoskeletal disease and stroke and heart disease and lung disease and diabetes, everything else, but nothing on dementia. And that put into my head, hey, we have to do something about this one day. So why did we do guidelines? There weren't any. Dementia's common, as we've said. Dementia's a national health priority. Dementia is now the second commonest cause of death in Australia. We know that clinical practice guidelines have been shown in other areas to improve care, and we know that dementia, and I've been very polite here, I've said it's not managed consistently well. I would have to say it's managed appallingly in some places. And there's lots of room for improvement. And the other thing is, for my general manager, having guidelines gives dementia clinical legitimacy, or clinical validity. It's like, yes, it's got a guideline, so it actually must be important. And it's the bottom point, because I don't think it's that important, but it is interesting. It obviously is to some people. So how do we actually do it? And I would not advise people to do this lightly. We took the NICE guidelines from the UK, so we weren't going to reinvent the wheel. They've got really, really good guidelines. They're guidelines on care of people with dementia. We formed a guideline adaptation committee of 21 people, and it was researchers, clinicians, representatives from lots of different backgrounds and consumers. And we actually met 3 times face-to-face, but we spent a huge amount of time emailing each other and talking about variations and all the recommendations. We finally got the version through. It went out to public consultation, and some of you may have commented on it. It was out for consultation. Under the NHMRC rules, it has to go out for 45 days. It's sort of biblical. But, no, biblical's 40 days, isn't it? But anyway, it went out for 45 days. And we did get a number of comments. Changes were made. But there's now 109 recommendations, but only 29 of them have evidence base behind them. What we did with every one of the NICE recommendations was actually do a mini systematic review around it. So huge amount of work, and it was done mainly by colleagues in South Australia. I think we just get the glory, but I can tell you they did the work over about 18 months. But it was fascinating finding stuff we're doing that has no evidence whatsoever for it, and stuff we weren't doing which has quite strong evidence. How do we do it? We launched them in Parliament House at Canberra. Susan Ley, the Minister for Health, actually came out of Parliament to do it, which we were very happy about, and hung around for half an hour. The two people on the left are really Kate Laver and Suzanne Dyer, really did most of the work for the guidelines. As I said, we just get the glory. But everybody was there, all the consumers, and I have to say since then the consumers have been really, really strong. They take the guidelines along to their GP or along to their hospital and say, well, you know, this is what it says you should do, which is actually a really, really powerful way to make changes. That's the guidelines address, but it's very long. Just Google. If you Google Cognitive Decline Partnership Centre, you'll find it. But just in the last couple of minutes, I just want to mention, I'll just give you a couple of examples. There's 109, I'm not going to read them all. Recommendation 8, and this goes to something that Lara said about people with hip fracture and dementia not getting rehab. People with dementia should not be excluded from any healthcare services because of their diagnosis, whatever their age. Okay? It's in black and white now. So I think that's really important because people do get excluded, particularly hip fracture. And we've done a study, and we're doing another one, that shows that people with hip fracture actually do benefit from rehabilitation. Recommendation 22, general population screening for dementia should not be undertaken. However, recommendation 23, concerns or symptoms should be explored when first raised, noted or reported by person, carers or family, and should not be dismissed as part of ageing. In a lot of our consultations, the consumers brought literally hundreds of stories of people who took 3 years to be diagnosed because their memory problems were dismissed as you're just getting old. And one of our big jobs, and we're actually doing consensus guidelines for GPs as well, which I skipped over because that's still in process, but they will be based on these guidelines. A big push is to get out to GPs, but it's also important to get out to the general population and say, you know, if you do have memory problems, ask about it. Because it is important. We do say medical practitioners should be alert to cognitive decline, especially in those aged 75 and over. So that's some of them. There's about promoting functional independence, that the health and aged care staff should promote functional independence in people with dementia at all levels of dementia. I see probably 15 to 20 new cases a month of people with dementia here and particularly down the coast, and we always start an exercise program if they're not doing it. A warning, I said to someone, get a dog, because they'd had a dog. I don't know if you've heard this story before. So they went out and bought a beagle puppy. This is a couple in their 70s. Beagle pups need a lot of exercise. They're lovely, but they're also very boisterous. Anyway, about several months later, this couple appeared at 4:30 on a Friday afternoon at the Batemans Bay Community Centre without an appointment, with a dog in their arms. I walked out and said hello and said, you know, you don't have an appointment. Here, he's yours. The final straw that morning had been that this gorgeous dog had eaten both the husband's $5,000 hearing aids. So, however, the advantages of a country town are that the secretary knew somebody who got onto somebody, and that dog was rehomed by 6 o'clock that night. Much to my relief, because I already had a dog at home. But if people have got a dog, do it. We really encourage that, particularly obviously in the country. The other thing I do, and this fits with what Kathy was saying, is that I encourage people to buy 1/2 or 1 kilogram weights from Kmart or Target and keep them by the kettle I do it. I have 3 kilogram weights by my kettle. And when I go and boil to make a cup of coffee or whatever, I do some resistance. I just do some exercises, whatever, do some exercise, do some squats. And we discovered, this is how we evaluated it, that we ran Kmart in Bateman's Bay out of 1/2 and 1 kilogram weights. So I thought, that showed at least they went and bought the weights. So promoting functional independence is really important. Be offered occupational therapy, which is what we're doing with the COPE intervention as part of our partnership centre. And recommendation 68, people with dementia should be strongly encouraged to exercise. Assessment and advice from a physiotherapist or exercise physiologist may be indicated. Maybe that needs to be, sort of really put out there. But I think those sorts of things are really important. And just finally, carers and families of people with dementia should be supported to build resilience and maintain overall health and fitness, and referral again to a physiotherapist or exercise physiologist may be appropriate. So we're really, really pushing the exercise side of things, because really, my comment always is, if you could put exercise in a pill, it would be the most effective medication ever marketed. Problem is, people won't take it. So, thank you very much.
Thank you, Sue. What a fantastic and inspiring talk with real practical implications. We've probably got time for 1 or 2 questions before we move on to the next section. Otherwise, we can save them for the end, or you can catch up with Sue later on. So, we did have one? Okay. Can't get your presentation.
Okay. So just title again. Congratulations, Sue. It's a very, very, good talk. Now, about the PETs, what's the evidence that PET will improve the patient, benefit the patient in force? It seems, maybe I missed it. You didn't mention that. You talked about the robot, but you didn't about the pets.
Pets? Evidence about pets.
Because you talked about the dogs.
Yeah, pets. So the evidence for pets. The evidence for pets in dementia is currently being looked at by colleagues at the Dementia Centre at Hammondville at the moment. They've got money to look at that. It's varied. We actually published an article, slightly tongue-in-cheek, many years ago about pet-related injuries that actually was shortlisted for the Ig Nobel Prize. We were beaten by the paper that said, that explained why woodpeckers didn't get traumatic brain injury every time they... So we thought that was fine. What we did was actually present a whole lot of cases of people who'd been admitted to our hospital with fractures because they'd fallen over, sat on, tripped over, whatever, their pets. And so when we wrote that, we had all these terrible letters from people saying, no, pets are wonderful. I think pets are wonderful. I'm not convinced about robotic pets. I did take a stuffed dog into one of my patients in a nursing home in Bateman's Bay. She was from Orange. She'd fractured a hip. She was immobile. She'd always had a dog, so I found this wonderful stuffed kelpie and I took it into her. She looked at it, she patted it for a minute, and she picked it up. She threw it against the wall. She said, "Bloody thing's dead." So my granddaughter has a lovely stuffed kelpie.
Fantastic, thank you very much. It's my pleasure to introduce Lorraine Lovett and Ingrid Hutchinson. So Lorraine is the leader of the New South Wales Falls Prevention Program at the Clinical Excellence Commission, the CEC. So the CEC, as you know, has a key role in building capacity for quality and safety improvement in health services in New South Wales. And so Lorraine supports the Falls coordinators and local health districts in the implementation of the New South Wales Ministry of Health Falls policy, as well as the National Safety and Quality Health Standard on falls prevention and harm from falls. Lorraine has a nursing background with considerable experience in aged care management, consultation and coordination, both in the community and acute care settings. So I'll introduce Ingrid at the same time because they're going to do a tag team. So Ingrid is the project officer for the Falls Prevention Program at the Clinical Excellence Commission, and she coordinates a variety of statewide projects and supports local health district falls prevention coordinators throughout New South Wales. And she has a Bachelor of Applied Science in Nutrition and a postgraduate diploma in health promotion. And they're going to tell us about or give us an overview of the April Falls Day month activities. So welcome Lorraine and Ingrid.
Thank you. Morning, everybody. So April Fool's Day, as all of you would know, is celebrated on the 1st of April every year. It's a fun play on words about a serious issue about preventing falls in older people. We'd like to give acknowledgement to Northern Sydney Local Health District, who came up with the idea for April Fool's Day back in 2005 when they were an area health service. Excuse me. So the purpose of April Fool's Day and April Fool's Month now, as we know it, is to raise awareness for falls prevention for staff, patients and carers in a way that's both informative and engaging. From the CEC perspective, we organise a working group that consists of representatives from local health districts, and we all come together. We work on the theme for the year, we develop the resources, the flyers, the posters, the presentations, and we do this each year within the CEC budget. We have no extra budget to produce fantastic extra resources, so we do this within our work and within our budget so that we can provide resources to you so that you can use them in your April Fool's Day celebrations. April Fool's Day continues to gain momentum, and each year more and more hospitals, community health centres participate in April Fool's Day, and now we're getting inquiries and from other states and territories about wanting to use our resources and promote April Fool's Day in their facilities, which is really great news for us. So these are some examples of some posters that we've developed this year. This year's theme was Share the Care, Falls Prevention is Everyone's Business. So we really wanted to focus on carers and working with carers in the care of the older person. As you would know, they can provide some really vital information to staff about the habits of older people, and they can really alert you to if there's any issues with their loved ones in hospitals that they may see before a staff member can see that. So this year, for April Fool's Day, we ran our first statewide competition for April Fool's Month, and we really wanted to gain some information about how different facilities have prevented falls or raised awareness within their facility for falls prevention in the last 12 months. So this competition, again, was borrowed from Northern Sydney Local Health District. They gave us permission to use the competition, which they also ran within their local health district. I'd like to also thank their communications department that assisted us with the development of the flyer. So this competition, it was really strong this year. We had some really fantastic entries, and it was so strong actually that today we're going to hear a presentation from the winners and then from 2 runners-up who also did some really great work in preventing falls in their facility. So I'd now like to introduce the winners of our April Fool's Month competition for 2016. It's Jane Marie Hunter and Jan Kurrle from Gosford Hospital from the Central Coast Local Health District. And they will now present on their work that they've been doing on preventing falls.
Well, actually, our presentation is a very simple one because we think falls isn't rocket science. It can actually be done very simply, incorporating the staff. So our title is Life is Really Simple, but we insist on making it complicated. Our fall strategies were actually a team effort. Firstly, we're a very focused, patient-centred team. We recognised we needed to do something, and we have all seen this situation before. There's the chair alarm on the table, the urinal or phone out of reach, unnecessary floor signs still up in the morning when you come on, trip hazards, cords floating around, slippers actually next to the bed but not on the patient's feet, non-slip socks washed and just drying, ready to go back on. Our high falls risk patients are placed in a room that is close to the nurses' station and a high area of visibility to all staff. The room, as you can see, has been painted orange on the walls outside the room, and the reason for this is to remind all staff that the high-risk patients may be placed in this room and should be placed in this room. The colour orange actually matches the fall stickers and the non-slip socks. 2 staff on our ward are actually allocated to this room on all shifts, and there must be also 1 staff member to remain in the room at all times. Music therapy has also been introduced into this room by our lovely falls therapist and music therapist, Jan, who's presenting with us today. Some of the nursing staff will actually try to change the community radio station to the modern R&B, but if Jan is working close by in the corridors, the music is quite quickly and swiftly changed back to 50 plus 93.3. So everyone knows. The music therapy introduced into the room has had a very settling effect on many of the patients. One nurse working in the ward has also introduced diversional therapy. It's in a box with all different bits and pieces, and the other staff have also taken this up. We also use Top 5, and it's implemented on all patients in this room, and carers have their input as well. Outside the room, there are actual information brochures for all staff and relatives. A small group of us actually went to RPA to visit the staff because they had put into good fall strategies, and we went to see how they did things so we could perhaps benefit from that. We actually have introduced a monthly falls map, as you can see, and we display that quite clearly up on M5 and outside the falls room, showing where each falls has occurred on the ward. These falls are then discussed with the staff at the ward meetings, and strategies are also brainstormed to reduce further falls occurring. So we're reviewing it constantly. I'll hand you over to Jan.
Oh, I'm so nervous. Anyhow.
Sorry.
There is now interested staff that have become Falls Champions, and these are acknowledged on the Ward Communication Board. The Falls Champions are known as the staff to go to for assistance and information regarding falls prevention strategies for their patients. We've also introduced hourly rounding. We did get these clues from RPA and we've adjusted it for ourselves. So we have put in place the 5 Ps to do this, in that we go to the patients and you're asking them, do they have pain? Do they need a pan? Are they comfortable? Have they got what they need, their core bell, their glasses, their bottle of water, and is everything that needs to be plugged in. Hopefully by doing that within the first 5 minutes of assessing them and talking to them, you're freed up then to go and do other things. We're updating of the welcome brochure handed to relatives and patients on arrival to the ward. The falls info is now in first place on the brochure, encouraging relatives to sit with patients and to notify staff when they are leaving. And we utilise the carers as much as we can. We always get our hints and clues from them. We do all about me's as well as the top 5s, and they're hugely helpful. And finding out what families are capable of staying with the family if they're really agitated, if it's a doable thing, then we can free up staff to do other things. There's now a combined falls meeting every 3 months between Wyong and Gosford neurology wards, where falls for the previous 3 months are discussed and strategies explored to minimise harm from falls. Before strategies were implemented, we were having 10 falls per 1,000 days, and we're currently sitting at 3, so we've done really well in the last 4 months. So thank you.
The above outlined strategies have also been well embedded into the culture of M5. It's actually a big culture change as well, and these are reinforced regularly throughout our meetings and ward meetings. As the NUM, I actually do review the IMS daily and encourage ward staff regarding the completeness of IMS documentation and ensuring that post-fall management is followed. which also instills pride into the staff and the added reduction to harm to the patients in the ward. These IMS and discussions are also minuted at the ward meetings. There has actually been limited financial cost to the ward, as we were due for repainting. We're a bit of an older ward, so we were due for repainting anyway. So someone had a little bit of a stash of the orange paint. As an on M5, I've also implemented staff rounding and asking simple questions such as what is working well, focus issues, going around saying anyone got any falls ideas or brainstorming on a recent fall, recognising staff for the job well done. Tools and resources are also discussed if we need any more falls mats or any other equipment or resources, and discussing what we could do better. So Jan and I would just like to thank you for listening to our falls presentation today.
Thank you.
Okay, we'd just like to present Jan and Jane with a certificate for the April Falls Month competition winners.
Oh, thank you.
Jane. Thank you. And
Thank you very much.
Congratulations.
Thank you.
Great. Thank you. Okay, we'd now like to hear from our runner-up. One of our first runners-up was Suzanne Berry from Pambula Hospital. So Suzanne will now give a short presentation on what they've been doing in Pambula Hospital for preventing falls.
So I'm just using that button, am I? Yes. The down arrow? Okay. All right. A bit nervous too. Hi, I'm Sue. I'm the nurse manager at Pambula Hospital. For those who don't know, Pambula is on the far south coast of New South Wales, and that may be what you're missing if you don't go down there. So we're a satellite facility to the new Southeast Regional Hospital in the Bega Valley Health Service. And we service places like Marimbula, Eden, Pambula, and over the Victorian border to Malakuta. Because of the excellent work that my team do, and I think it's really important to acknowledge their part in this, so I brought some of my team with me. At the time the falls issue was identified at Pambula Hospital, we were a 26-bed adult mixed surgical medical ward, looking after a client base that was generally over 50, and we had acute and chronic complex needs. But historically, Pambula has had its challenge with inpatient falls, and between the years of 2012 and 2015, we had an average of 40 falls per year. It hit its peak in 2015 when we had 3 SAC2 incidents. And does everyone know what a SAC2 is? Yeah, pretty much, okay. So it was pretty big. So we decided something had to be done. So in alignment with the New South Wales Health, Prevention of Falls and Harm from Falls in Older People, 2011-2015. Our aim was to reduce falls risks and fall-related injury among admitted patients, provide guidance to clinical staff in the provision of optimal screening, assessment, treatment and discharge planning for patients with increased risk of fall, and to ensure appropriate action is taken if a fall, an incident or injury from a fall occurs on admission. So how did we do it? We actually put in, one's not on there, but 5 things really. Intentional rounding, patient safety huddles, multidisciplinary rounding, and recruitment of AINs for specialling and volunteers for distraction. So I'll talk to you a bit about intentional rounding, and I think the group that won it actually have talked a bit about it as well. So intentional rounding is looking at pain, personal care, placement of things they may need, and position. So of course, the staff didn't take to this really well. It was another form that they'd have to fill out, and they were initially very resistant. So what I did, I went round and spoke to them all one by one, showed them the literature, spoke to them about the effects that it could have, and they finally agreed to do a 3-month trial to see how it went, and we're still doing it 9 months later. The next thing was patient safety huddles. A post-incident huddle occurs immediately following an incident, such as a fall, with the relevant team members, including the patient and carer if they can. You look at what happened, what gaps occurred that may increase the risk of the incident occurring, and what we need to do in future to reduce the risk of that happening again. And importantly, it's always about the documentation, so documentation in the notes with actions that may be needed to do in the future. So the next thing we did was multidisciplinary patient ward rounding. At Pambula we do that with 2 formal rounds per week. We're a small hospital, so that really works well for us. We include the physio, OT, care navigator, nurses, and most important, the patient and the carer. The team discusses inpatient care and risk to safety and discharge planning. And finally, I just want to talk about the recruitment of the AINs for specialling and volunteers for dementia patients. We found that great opportunity to employ these people on a casual basis, and they actually stay with the high-risk falls patients. The AINs must complete a Cert 3 in acute health services, and volunteers receive extensive training prior to commencement, and everyone gets mandatory training such as WHS and manual handling. So this is what we found. We've had a huge drop. From the implementation in 2015, we've seen a large reduction of falls, and those people who have fell have actually had less injuries. I've really been instructed by my educator to mention that without the education that went with these processes, nothing would have worked, and she's right. That's it. Thank you.
Thank you, Suzanne.
Thank you.
Thank you. Congratulations. Thanks. Okay, I'd now like to introduce our second runner-up, Ian Steele from Braide Hospital, and Ian will be talking about their Catch It Early program.
So at Braide Hospital, we're a rehabilitation unit. I'm a physiotherapist and focus mostly on gait errors, so my focus is basically towards gait errors. The Catch It Early program focuses on falls reduction in hospital by teaching patients and nurses to recognise and correct gait errors before a fall occurs. It's common in rehab hospitals for nurses to be relied upon to continue mobilising a patient who may still not have full control of their balance and gait. Often mobility will be avoided due to the patient being reported as being either wobbly or unsteady, prolonging their stay and increasing their fall risk. So I developed the Catch It Early program to try and improve the situation. I feel that falls can be prevented by empowering nurses and staff with gait error detection skills via tutorials. So I gave tutorials to all the nurses. The flow is that the patient has a gait error that I correct via physiotherapy techniques and give them a strategy to correct their gait. The nurses learn to recognise this and prompt the patient to actually correct their gait using the strategy that they've been taught. Their balance is regained and they reduce the risk of fall. The patients often have an observable and discrete gait abnormality that predicts their loss of balance, which is what I teach the patient. I teach the patient to catch it early, and I teach the nurses to catch it early too, hence the Catch It Early catchphrase. So the concept of teaching the nurses how to recognise and document gait errors leads to a reduction in near misses and the falls associated with this. So the documentation is also an extremely important part of it in the communication. So it gives a unified approach to assisting patients to reduce fall. In the tutorials, I try to keep it fairly brief and interesting. I use analogies. For instance, I talked about the tell, which is a poker strategy of how to recognise someone making a move or having a bluff. The tell for me is very specific gait errors, including narrow base of support, body twisting or tilting or lifting. It's all easy to recognise when the nurses are educated on actually what it is. So the tutorials I give are based on some basic observational skills. I don't know, early in my career, all these belts were called pelican belts, and people would ask, what are they called, pelicans? And I say that they were made from pelicans. For me, as a physio in rehab, I think that they're often overused. I think the problem with pelican belts is that they're used to actually tugboat the patient and move them around, and I think that's not exactly what they should be used for. I don't believe they're actually a walking aid, and so I teach the nurses that they're used to assist a patient to regain their balance and use a strategy that I've taught them whilst being held up, so that the patient is held but not guided. They're told to use the strategy that they've been taught to correct the gait error. Also, in rehab particularly, we track near misses, probably more so than even falls, and turning and sitting seems to be a major problem for people. Obviously, it's a rush, so people turn, they don't complete the turn. So I teach the nurses to really focus on planning, focusing on completing the turn, to step back and to use the hands, so that the nurses know why we focus on that. It has been a really good response from the nursing staff. I think that they understand what I'm trying to do, and when they understand how I prompt a patient and how I correct the gait, they feel that they're now part of the rehabilitation process instead of just dragging people to the toilet. They can now tell me what went wrong. Instead of saying wobbly or unsteady, they can say that patient made a step error or was leaning too far, and they can even document that. And for me, that's extremely important, so I can go back to the patient and say it's been recognised. There has been a reduction in near misses, which in rehab is probably the most important thing, and it's improved the confidence of the nurses and the patients, to the point of the nursing staff actually have created a little extra part of the lots of information they keep on their belts, and they have the phrases I've given them in the tutorials that give me information on what the patient has done wrong, which is like a foot placement error, having an uncontrolled lean, didn't complete a turn, had a hard landing or twisted torso, and they're more than happy to tell me about these things when I come on the ward, because they're really proud of the fact that they can talk to me in the language that I understand and that they can understand what's wrong with the patient. So that's it.
Thanks to all our winners and to the runners-up. I think they should all be commended for the great work that they've been doing on their wards to prevent falls.
Thanks, Ingrid. That's great. We've had a range of different things. I'm just going to take you a quick, very short snapshot of what I've seen of different activities across the state for April Fools. Prior to that, I just wanted to say to Ian, that was really excellent, because one of the areas of work that we're now talking about with the Falls coordinators and work that we've just completed is around mobility and how we actually have keeping people safe when they're mobilising in our care, and more importantly, because we've got increasing numbers of older people, and when they come into our hospitals, I think sometimes we think they're safe because they're there walking, but we actually haven't had a safe appraisal of that walking, and we get staff that think, oh, they're fine, they can go on their own, they're independent, and it's not the case more often than not. So to have physios and other staff working to support nurses to get a better understanding about mobility and how to keep people walking or correcting walking patterns and walking safely, I think is really critical to success of good care, particularly in our acute environments, but wherever we're with people. So just a quick plug too. For that end, what we've done, we've made some videos. We'll put it on over lunch or when you come back in early. We've made a quick set of little videos. We did this in Coffs Harbour. It's around safe use of mobility equipment. And it's not to take away from the role of the physiotherapist and other health professionals, but it is to support people understanding and teaching people how to use their walking aids or walking equipment safely. So we've done one with a wheelie walker, we've done a frame, a walking stick, a high arm support frame, and a pickup frame. Just the four. And what it does is just talks about the safety precautions, how to fit it to make sure it's correctly fitted, and then what the correct walking pattern would be when you're using that equipment. So we've just had them delivered on USBs. If any of you are interested in having one that you think will be useful to support education in your facilities, we would be keen to hear about that so we can get more done and get those sent to you. So that's just a little plug about some more resources that we've developed more recently. Now, back to what I've seen in April Falls. There are a number of Falls forums across the state, and this one particularly was one in Western Sydney. We've done a couple in Western Sydney during April, and an acknowledgement to Kitty Kerr, who is our Falls coordinator for Western, to help pulling this one together. They all have a different flavour. It's fabulous when you go out to local health district land, and we get the practitioners themselves coming in and sharing what they're doing. So you'll see there a picture with it's a piece of material, and it's a diversional therapist who's got some sort of fiddle things. Now she's working with a whole community of knitters and sewers out in her community, putting together these little fiddle aprons and fiddle mats for people who might be restless and agitated in our hospitals. The one that she's holding her arm up is a knitted sleeve, and this is a trial in one of their acute wards, because you know when you've got that person who's restless and agitated with IVs and all they want to do is pull them out, well, she's hoping this is an attempt to sort of, with little things on it, that they might just actually play with that. We're just examining that at this point. Now, for those people worried about infection control, we know. It has to be thrown out. It won't be reused, so she has to have a lot of knitters engaged if it's going to be successful. The other one where I talk about mental health, do you know at Cumberland Hospital, they have done a fantastic job. And credit to them, I hope someone's here because they deserve congratulations. They have taken on looking at falls within their long-term chronic mental health patients. One of the things that really intrigued me, for all the things they did, they talked about the older person, particularly the shuffler, you know. Classic walking around their health campus. And what they're doing is actually teaching them to look up, and they're actually teaching them heel-toe walking. And within that, they've actually improved their whole sense of well-being. It's just amazing what the benefits are. So the staff are working with them. They know how to begin to start helping to support them even just with their walking, lifting their feet, heel-toe walking, preventing the shuffling. That's just one example of what they've done. In the top, we've got, in the afternoon, we had a whole session and staff from all their hospitals. I might forget them if I say one and not the other. Mount Druitt, Westmead, who else have I got there? Blacktown. Who else was there? Auburn, sorry, yes, we were at Auburn. And look, the sense of collaboration with everybody together, working together in the room was fabulous. What they were really wanting to focus was, how do we improve our communication with patients? How do we really get to work with them and engage them in care? How do we really understand what their needs are? How do we work with the families and understand so that we can develop better plans of care, but we can communicate more effectively? So they did some little scenario work, and we did some problem solving on paper and so on. A great start, and they're really keen to continue that level of work. Very significant for us, I think. And the other thing was that they actually did a flash mob in Blacktown, the oldest flash mob. It was on video, I don't know that we can show it anymore, but they had large numbers of people out there, and Trish Nove, where are you? I think Trish and Kitty were out there teaching people how to do the 4 simple steps that we talk about in falls prevention. I want to talk about Hunter New England. We had 2 forums in Hunter New England, one in Tamworth and one in Taree. And I've just put this up to show a trend in their falls trending down across their local health districts. Now, we are seeing trends across other local health districts as well. But I had this slide so I could show it. But we hope in time we're going to be able to have much more effective data to demonstrate where we've got good work happening, and we can show slowly these trends of falls going down within our hospitals. So I'll show you some. This was Manning Hospital, 44% reduction in falls. and staff are committed to achieving zero. Now that is a real accomplishment if they can do that. What did they do at Wingham Hospital? So they went and asked them questions. Who was falling? People with impaired cognition. What were the actions they might need to put in? Increased supervision, do a falls plan with them. When were they falling? So they looked at the times they were falling and talked to patients and staff about where were they falling. So they identified the key areas where they are falling. And what could we do to support the staff? So in terms of the training as a facility as well. Look at this rate, 70% reduction over 6 years. So it's not, as someone said I think earlier, it's not rocket science, but it is a combined collaborative effort. And there are lots of little different strategies that we can do that can make a difference. I just want to acknowledge too, before I move on briefly, at Hunter, New England, we had a falls coordinator, Patsy Burke. Some of you will remember Patsy. Patsy's actually retired. She's gone on to leisure life activities now. And it was significant there because we had patient stories, and one of the stories in Tamworth was her mother. And her mother presented at a forum about 4 years ago, having had a fall, and a physiotherapist, Judy Coates, who has presented here as well. Judy talked with her mother and worked with her in the community about strengthening balance and strength and exercise. Her mother came back again, we were thinking about 6 years later, 5 to 6 years later. Her mother is getting up towards, I think, late 80s, early 90s, does walk with a walking frame, but her mother has had maximised independence for the last 6 years, continuing to live independently at home because of the interventions that she's had from good collaborative care and a physio being able to support her in doing muscle, increasing her strength, but more particularly balance exercises. And she gives her due to that opportunity to have that level of engagement. So I think there's a message in that for us as to how we work to continue to support those people in our care who are being transferred back to other facilities and home, but more particularly to encourage them in exercise as well. We did a forum down in Murrumbidgee with Nasmall. He invited us down, and this was slightly different focus again. In there we actually took Anne Axum, who will be talking this afternoon, from our patient care experience team at the CEC. And what we were talking there is around how we do improve that relationship between the patient and the care and the conversation. Now, in our rurals, as you'd appreciate, it's a long way to travel, so we did this all by teleconference. We sat in a room with Nasmall, the three of us, and we talked and we shared with video conferencing with our sites across Murrumbidgee Local Health District. So I've only just given you a very brief snapshot of the activities that have happened. There's been a lot more. I've had a lot of lovely little stories. Henley Health Service comes to mind. Henley's written, they've had funding cuts. They can no longer get a physio, they can't get a podiatrist, they can't get a dietitian, and the list goes on. You go, oh, this is just a common story. But it hasn't stopped them from being creative and looking at what they might be able to do themselves as staff to adapt and to look for other ways of getting resources to support the care that they need. So I want to just acknowledge them and the little suite of information they sent in to us. So all of this information will be put into a newsletter, our April Falls newsletter, which gives an overview of the activities that have happened across the state. And I just want to thank those that have participated in our April Falls. Keep it up. We are continuing on the journey together. Thank you.
Thank you, Lorraine and Ingrid, and the individual award winners. That was, again, a very inspiring, fantastic session. So we do have time for a couple of questions, and then we also have a few announcements before we go off to lunch. So I think we've got a question here. Rick's very enthusiastically waving.
Hi, I'm Rick and I'm a physio. It's really encouraging to see that you've got some long-term data about reducing falls in hospitals. Is there data in residential aged care? Because my problem with a lot of research, it's 6 months or 12 months, and I believe that there needs to be a long-term view of falls reduction. Can you give us some positive stories about this happening in residential care? I gather there's not.
Lara, do you want to answer any question about collecting data in residential aged care? She's the data girl. Sorry, I put you on the spot.
It is difficult. Currently there isn't a lot of data available in residential aged care. Like I said, I think it will become more so in the future, particularly because we're now beginning to be accurately identifying who's in residential aged care. So, to get it on a statewide level, to be able to show these big things, I think it's coming, but it's certainly not there yet.
And we've got a researcher that can answer as well.
I'll give you a quick answer. I think the challenge is that the successful programs in the literature really require a lot of investment. So I mentioned that Becker program from Germany actually did have really impressive reductions, and there's been a number of other trials internationally. The other people in New Zealand, they tried to implement it more cheaply, and unfortunately it wasn't successful. So I think it is a real issue in terms of investment in these types of interventions in residential care.
And I have a comment to make in that, no, we don't, Commonwealth level and at a state level, we can't easily pick data around where falls are happening within residential aged care. We do get a lot of admissions from residential aged care for fall-related and falls and fall-related injury. Just by way of that too, where a lot of some of our data we can identify comes from New South Wales Ambulance. New South Wales Ambulance responds to 4,200 calls for falls a month. So we've just received a little summary of some of that from the geographical areas. That's something for us to be considering and working. Not all of those will be transported to hospital, but they are keen to be working as to what interventions they can start looking at and be proactive in getting earlier intervention at home. Back to residential aged care, we've worked with a number of residential aged care providers. Some of them are here today, some physios and others who are really interested in working and improving. And we do have some pockets of work where there's good work that's being done. We're not funded formally to work directly into residential aged care, apart from what we have responsibilities for covered under our health agreements and our multi-purpose services. So we are conscious of working and trying to support where we can and try and highlight resources where they come available. We're aware there's a lot more work to be done.
Okay. I think might have one more question there. Were you? Oh, okay. There.
Hi, I think probably this might be able to answer from Susan or Dr. Lara. I was just wondering whether there was any evidence about the increased supervision in reducing falls. What we've seen this morning is clearly there are in the individual hospitals or facilities that there is a decrease when there's increased supervision, but is there any formal evidence available at this time?
I can see Susan shaking her head. Lara, did you add to that? I think it is often used as part of a multifaceted strategy, but it hasn't been tested individually as far as I'm aware. Did you want to add? No. I could go. Okay. All right, I think we can have one more question and then people can follow up individually. Oh, over there.
Hi, I just have a question for the Gosford team, girls down the front. I was just wondering how often you have to go outside your nursing hours per patient day to supply the 2 nurses in the room.
I'm really loud. We actually have really excellent staffing in our ward, and we utilise AINs as well. So our morning shift, Monday to Friday morning shift, we actually have 11 staff on for 32 patients. I failed to mention before, we're actually neurology. So we have strokes, brain injuries, Parkinson's, much more so than just the dementia patients or the age patients. And we do our falls risk assessments on admission. If they have a fall within the admission, they're straight away reassessed. And anyone who we deem is a really high risk goes into that room, and we make sure there's somebody in that room at all times. You're not allowed to just walk out to go and get something. Someone has to stay in there and be visually watching, and it's reduced our falls hugely. But yeah, it's a difficult ward because of our behaviours that we get within neurology. Yeah, so yeah, we do have excellent staffing.
But they don't seem to think we need those numbers on weekends. Go figure.
Fantastic. All right, we need to wrap up this session now. So I'd just like to thank both Lorraine and Ingrid for facilitating and reporting on these amazing activities. And of course, congratulations again to the award winners. And I think, yeah, they're very fantastic examples of great innovative programs. So thank you again to all the speakers. So lunch and the trade displays will be in the and Pacific rooms, and also the Cotty Lounge, and all special dietary requirements will be served in the Greater X room. The meeting of Stepping On coordinators with Vincy Lee and the Stepping On Program Manager will be in the Pollard room from 1 p.m. Please bring your lunch. The afternoon sessions will start promptly at 1:30. Everyone you can start moving out, but just be quiet please, because people need to listen to the announcements. So the concurrent afternoon sessions will start at 1:30. The acute and subacute care session will be in the Lyceum on the next level, and you need to take the stairs from the Cotty Lounge to get there. The dementia care update will be in the Smith room, which is on this level, and the exercise session will be here in the Wesley Theatre. If you're not able to attend the afternoon sessions, please fill in the evaluation forms at the registration desk. And a further announcement for anyone who left luggage or bags at the registration desk, they've been stored securely, and you can find out where they are by going to the New South Wales Network table to the right as you exit this room. So thank you very much for your attention, and thanks again to the fantastic speakers. Thank you.